start. Bismillahirrahmanirrahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation CME meetings. And today we are indeed with one of the pathology lectures and pathology meetings by our eminent professor, Professor Wesam Ismail. And I'm a pleasure today to have one of my dear friends as a moderator. He is Professor Hatem Darwish, Professor of Nephrology and Medicine in Cairo University, and really one of my sincere friends and one of the experts in nephrology, especially in clinical nephrology fields, and especially in think that he took his fellowship in France the past years, which is other polycystic kidney disease. I am pleasure today to have him as the moderator of this session, and also, as usual, we are pleasure and expect a very interesting and scientific session from my dear friend Professor Wesam Ismail, the head of pathology department in Bani Suef University. I will leave the floor to Hatem to lead this session and come again, as usual, by the end of the session, lecture for discussion. I would like to thank before I leave our coordinator today, Dr. Islam Abu Ni'ma, lecturer of internal medicine and nephrology in Cairo University, who is the coordinator for all of his work in CME chapter, and welcome all of our attendees and our professors, especially Professor Ayman Rifai, the current president of Egyptian Nephrology Society of Nephrology and Transplantation. Please, Hatem, Professor Hatem, take the floor to introduce further Professor Wesam and lead this session.
Assalamu alaikum. Shukran Yasser for your kind words, and it is my pleasure to introduce my dear friend and colleague Dr. Wesam, and she is well known, and she doesn't need really a long introduction. She is well known for all of us, and she has a lot of help. She helped us a lot in our cases. She is a professor and the head of pathology department at Bani Suef University, past chair of ISN Renal Pathology Working Group, and currently chair of AFRAN Renal Pathology Committee. Without any further delay, Wesam, start your session, please. Thank you.
Thank you very much, Hatem. Well, thank you, Yasser. And it's a pleasure to be with my old dear friends, and always a pleasure to participate in this really very always a very good activity of the Egyptian Society of Nephrology, and appreciating the effort that Professor Yasser, the dynamo behind this continuous webinars that we have weekly. I'm going to go very basic today, and we're going to discuss what I think, as we were just talking before the session, is one of our day-to-day practice, an important topic, and something that each of us who is involved within the nephrology field actually deals with, which is lupus nephritis. And I will start with the concept of how we look at classifications, or how we are classifying renal disease currently. And I want to remind you that in more than 50 years, in the last 50 years, we have changed the way that we look at a lot of renal diseases. And we have tried to have a different approach to the classification and eventually the diagnosis and the prognostic index of what we see as per pathology and clinical presentation of the patients. This had included a lot of immune complex diseases, anti-GBM, mainly lupus nephritis, the way we learned to look at post-infectious GN, the development of C3GN. Also, it had been applicable to ANCA disease, to how we have considered DMA and HUS, the classification of the disease of transplanted kidney, membranous glomerulopathy and how we look at it, FSGS and how currently it's a clinico-pathological approach, the classification of amyloidosis, and so on. So we have been changing the concept that we look at diseases. And when if we want to really define what we mean by heterogeneity, then we are talking about lupus. This is always the problem about lupus, and maybe what's so interesting in lupus, that it is really a disease with a host of different antibodies and pathogenesis. It affects all compartments of the kidney. Always remember this. It's not only a glomerular disease. It affects glomeruli, tubulointerstitial, and the vascular compartment. And in the glomerulus itself, it causes lesions in the mesangium, lesions in the endothelium, in the glomerular basement membrane, as well as in the porocyte. So it's a disease which is heterogeneous in the pathogenesis of it, as well as in the presentation or the pathological changes that we see. Classifying lupus glomerulonephritis has been a tale as old as time. And since we ever started to have classifications in medicine, and we've been trying to classify lupus glomerulonephritis. And what's unique about the classification of lupus glomerulonephritis is that it's one of the rare diseases that have been classified by so many organizations. So we have the original WHO classification 1974, modified in 75, modified again in 1980, then again in 1982, and then another modification in 1995, till then when there was another effort by the International Society of Nephrology and the Renal Pathology Society to have a classification of lupus glomerulonephritis, which was in Colombia 2003. Now 21 years had lapsed, and only 4 years back, we have a revision of the ISN-RPS classification for lupus nephritis, and it's still the first phase, as I'm going to discuss. So the classification of lupus glomerulonephritis is still an ongoing story. We don't have a new classification now. We are still using the classification that we know of in 2003. Why do we need classification, and why it is so important that we classify diseases? Because it's important to standardize the criteria that we diagnose and classify different diseases accordingly. So classifications allow us to have standard histological criteria, to unify the nomenclature, that nephrologists and pathologists will speak the same language, and it facilitates clinical management. If we want to do trials, to have treatment guidelines, to really evaluate prognosis, or to have an idea about pathogenic mechanisms, we can do this through classifications. But my most important point is that classifications are not only for pathologists. Classification are both for pathologists and nephrologists. So you have to understand the classification as well as us. And in the past, most of our classifications in relation to renal pathology or renal disease were basically pure morphological classification. All of these classifications were based mainly on light microscopy and electron microscopy studies. And if you look back, as I said, 20 years back, 25 years back, this is the way classification were, like MPGN classification, for example, with type 1, type 2, and type 3, like membranous classification, which is stages based on EM, and all of this have changed because the present, our classifications are based on etiology and pathogenesis. And since we are discussing etiology and pathogenesis, this where immunostudies now are important. So current classification of most renal diseases are now based on immunostudies. They are not based on morphology, but rather they are based on the pathogenesis of the disease. What's behind this morphology? It's not the morphological classifications anymore. And not in the so far future, we are now counting also to classify via gene expression profiles. So this is the Colombia 2003 classification, as you all know. This is the original one, which was published in the JSON in 2004, where we had 6 classes and we had subclassification of class 4. And the main objective at that time was, again, to standardize definitions, emphasize clinically relevant regions, encourage uniform and reproducibility and reproducible reporting between centers. It's very important that between different centers, that the pathology reporting is standardized and reproducible, means that it can give the same idea or uses the same criteria and basics. Now, as I mentioned, we still use this classification, but this classification had some modification over the 20 years it's been used than the original version. This is why I thought it was important to go through it again, because if anybody is checking the literature or looking at the original classification, which was published in 2004, might be surprised or might wonder why we are not using the same exactly like the classification, why there are still different pathology reports, why some pathologists still report as the original 2004, and why other pathologists do not report in the same way. Okay, and I'm going to highlight the major changes between the ISN RPS 2003 classification and the WHO classifications. And I want to say the WHO classifications are obsolete. We don't use them anymore. So in 2003, the first change was that we have class 1, which was normal, which was a normal category in WHO, that this is minimal mesangial lupus GN. By light microscopy, it's normal. By immuno or by EM, we have mesangial deposits, minimal mesangial deposits, and this is what we call class 1. What does this mean? It means to you that we cannot diagnose class 1 lupus based on light microscopy only. And in lupus, you have to know that it doesn't make a difference whether we use immuno or EM. In anything else, we always say in order to diagnose IgA, in order to diagnose C3, in order to diagnose light chain disease, we need immuno. It's not enough to have EM because we need to know the type of the deposits. In other diseases like minimal change, like FSGS, like C3, if we want to know if it's dense deposit, we need EM because we also need to see where the deposits are and the pattern of the deposits. But in lupus, it doesn't make a difference. It's either we use immuno or we use electron microscopy, because this classification depends on the site of the immune deposits. And I'm going to sum up this up again. So it's on the site. So either we do immuno or we do EM. However, the point is, in class 1 cannot be diagnosed on light microscopy alone. And as I mentioned, the major change was to eliminate a normal renal biopsy, because we're not supposed to have a normal biopsy as a manifestation of disease, and it should not be included in a classification. This is a fundamental contradiction in terms. And then we have class 2, which is classified as mesangial. Now, this is where you see mesangial proliferation by light microscopy. But again, to confirm that it's class 2, we need to see mesangial deposits by immunofluorescence or by immunohistochemistry. And this picture that you see is immunohistochemistry. This is how immunohistochemistry or immunoperoxidase looks like, and the positive are the brown. You can see a brown in the mesangial areas, so we know that this is class 2 lupus. Of course, it's basically for IgG, C3, and usually IgM and some IgA. In the earlier classifications, there was a subclassification for mild, moderate, and severe. Now, as per evidence, it doesn't make a difference with the patient. There is no difference in prognosis or in response to treatment, whether the mesangial proliferation is mild, moderate, or severe. So they are all grouped under the same class, and it's mesangial proliferation. And within class 2, this also allows for the existence of rare subendothelial or subepithelial deposits, which we can detect by immuno or EM. So because this is lupus, and because this, as I mentioned, it's a host of so many different, a host of different antibodies, we can allow, if we can see a single subendothelial deposit here, a single subepithelial deposit here, but the dominant deposits are mesangial, so this is class 2. And then we come to class 3, which are usually is what we call proliferative classes, which are class 3 and class 4, which are usually the main indication for the biopsies that you take. Now, the difference between class 3 and class 4 is that class 3 involves less than 50% of the glomeruli, so it's focal, and class 4 involves more than 50% of the glomeruli, so it's diffuse. This is the main difference. Otherwise, these two classes are more or less the same. Now, in the original classification, there was an attempt for a different scoring system where we used letters, A for active, C for chronic, or AC for active and chronic. Now, we don't use this anymore. These letters have been eliminated from the classification, because at that time, when we have done a survey with the nephrologists, and by the way, it was at that time I was still training, and it was my professor, the late Professor Magdi Francis, and we've done this survey together, and we've asked the nephrologists at that time whether you would like us to keep using the activity and chronicity indices, or whether that we just substitute them for the letter A for active and C for chronic and AC for chronic and stop scoring and stop writing figures, they said no, they still wanted the score. And that these letters doesn't really mean anything, or it's not significant for them. So, and eventually in the subsequent literature and in all the studies which have done validation for this classification, these letters were eliminated. Then class 4, which is diffuse proliferative lupus GN, meaning that we have more than 50% of the glomeruli. And also this class in the original classification included the letters A for activity, C for chronicity, or active and chronic, so we use A and C. But this class also had a recommendation that we have to indicate the percentage of active and sclerotic lesion, that we have to indicate the percentage for benign necrosis and or cellular crescents, because as we all know, this is what makes a main difference in the treatment of the patients. And so more or less, it's again a form of scoring or using the same scoring indices. There was also a most controversial entity because at that time they have subclassified it into segmental or global, which is 4S and 4G, thinking that patients with 4S have a poorer prognosis than patients with 4G, meaning that the lesions involved are segmental in the glomeruli or global. However, again, with the validation studies of this classification for the following years, this by, I think, 2009, maybe earlier, the subclassification of S or G was completely called off. It was canceled and we stopped using them because really it doesn't make a difference and it does not have any difference in the prognosis of the patients or the response to treatment. So these changes were already reflected on the classification before even we think of revising the original classification, which are 2003. So you might find currently some pathology reports which come out reporting class 4, just class 4 lupus with chronicity indices, but you still find some pathologists who are sticking to the original classification 2003, where they still can report class 4 as class 4 S or class 4G, and they can still include the letters which are active chronic or active and chronic. This is one of the lesions that we see. I'm going to look at this again. This is mainly all of them are examples of class 4, and I'm going to go through them again. And then we have class 5, which is membranous lupus GN. Now, I know that you all know these classes well and that you know that this is membranous. I'm just highlighting some points which could be confusing to our junior colleagues. The class 5 membranous is simply a membranous GN. It looks with under light microscopy, under immunofluorescence, and with electron microscopy as a membranous GN. It looks exactly like a regular membranous GN. So again, there is no way that we would know that this is lupus related, except if we have the serology, which tells us that this is lupus. If the patient's phospholipase negative, NAL1 negative, thrombospondine negative, so it does not seem to be primary membranous. If we can do X1 and X2 in membranous, which are related basically to lupus or autoimmune membranous secondary to autoimmune diseases. And now again, this helps. So this is also an important marker. Or for example, this membranous also expresses IgA as well as IgG and C3. And I'll come to the immuno, or maybe we can discuss it now. That although it's that what we know about lupus, that this is a full house picture, and that most lupus, that this is how we should diagnose lupus, that we have a full house, meaning that you have IgA, GM, and that you have C3 and C4, of course, because this is a lupus GN. However, in reality and in day-to-day practice, you don't always get a full house picture, and it's still lupus. The most important thing that that in adults that this is IgG positive, because in children it could be IgA and it could be the dominant antibody, not IgG as we see it in adults, and not all the time you have this full house picture. Also, this is membranous, as you can see, a very regular membranous in the silver with spikes and so on. It's still class 5, and it could still be primary membranous. It all looks the same. The other important point with membranous is that the combined clauses. Now, this is one of the common clauses which can have combination. Means that we can have class 5 with class 2. So you can have dominant mesangial deposits as well as dominant subepithelial deposits. Or you can have class 5 with the active classes like 5 to 3. So the patient is basically class 5, but they are transformed or they are having an attack of activity. So we have proliferative lesions as well, whether they involve less than 50% of the glomeruli or they involve more than 50% of the glomeruli. The threshold of our combinations is 50%, meaning that if I have subepithelial deposits in less than 50% of the glomeruli, and we have other subendothelial deposits in the other 50%, then this is a class 5 to 4. If we have subepithelial deposits in more than 50%, then this is also class 5 to 3, for example. The important point is that there is undue emphasis on the subclasses of class 5, meaning that there is undue emphasis on the combination of the classes. And as I always tell my trainees, they come running, it's class 4, but it seems that the patient has class 5 as well. And we always say it's not important. The important thing is that the patient is in activity. When we treat the activity, you could also treat class 5, or if the patient remained with residual proteinuria, then we are going to know. So always, we don't need to have undue emphasis on combined classes. It's more important to recognize that this class could have combined a classification, and this is why the subclasses, which was with class 2, class 3, or class 4, were eliminated because they are not that important clinical-wise. And in addition to this classification back in 2003, and I think this is one of the main, either that this class is going to be eliminated in the new classification or it's going to be modified, is class 6, which is advanced sclerotic GN, because this requires that more than 90% of the glomeruli be globally sclerotic with no evidence of ongoing activity. This is really a very, very rare clinical scenario. We hardly see it, and you hardly see it in biopsies. So we do see patients with more than 80% global sclerosis, but we cannot classify it as class 6 because they do not fit the criteria of class 6, but they are actually class 6. And they could have minimal activity or no activity, but we have no option according to the classification. And because the nephrologists and you guys want a class of lupus, what is the class of this patient? So the option then is that we're going to classify it as 4 with extensive chronicity. So this class is a problem because my own personal opinion or my own judgment on the biopsy says that the patient with global glomerulosclerosis more than 75% has to be classified as class 6 or at least 80% because this is almost end stage, but we cannot put it as class 6. And if the patient has minimal activity, it is still minimal activity and it's not worth aggressive treatment because there is nothing we can do for this kidney at that stage. However, again, we're not able to classify it because it's only more than 90% of the glomeruli. So the problem with this class is the definition of the class, and that actually in actual clinical life and day-to-day practice, this is a scenario or a condition which is rarely met. It's rare to find a biopsy patient with more than 90% of glomeruli globally sclerotic and with no evidence of ongoing activity. So as I mentioned, the classification basically, or the lupus classes that we have right now, are dependent on the site of the deposits. This is why we can use either immuno or EM to classify, and we don't need both of them. Why immuno is not we can be substituted by EM? Because it doesn't make a difference whether, the antibodies we're seeing are IgA or IgG or IgM or C3. At the end of the day, all of them might be present with different percentages. We might be able to detect some and the others are not. But the important point is the site of the deposits. This classification, the lupus classification, is dependent on the site. This is why some of you even use this terminology, and they say mesangial lupus, which basically refers to class 1 and class 2, or proliferative lupus, which basically refers to class 3 or 4, or membranous lupus, which basically refers to class 5. So this is where we have class 1 and 2, where you have the deposits mainly in the mesangial areas, as you can see. This is 3 or 4, where you have the deposits in the mesangium and subendothelial, but you can also have some rare subepithelial deposits. And then this is class 5, where you can have some mesangial deposits, but rare subepithelial deposits. And then comes the combinations. How do we diagnose the combinations? As you can see in this patient, you have extensive subepithelial deposits, in this cartoon, I mean, and you also have extensive subendothelial deposits. So this is how we classify lupus. We classify lupus with the dominant site of the deposits. So most of the glomeruli have mesangial deposits, and this is the most dominant deposits, the most extensive deposits that you see. So this is mesangial lupus. Most of the glomeruli have subendothelial deposits, irrelevant whether we have mesangial, some mesangial deposits, whether we have some subepithelial deposits. Still, the dominant site of the deposits is subendothelial. So this is proliferative lupus. Whether 3 or 4 depends on the percentage of glomeruli affected, whether it's less than 50% or more than 50%. If the dominant deposits, or if the deposits dominantly are present subepithelial, then this is class 5 lupus. And if we have codominance, so I have subendothelial deposits and subepithelial deposits, then this is a combined class, whether 3 or 4 plus 5. And as you see here, we also have class 3 plus, and class 3 is plus class 2, or whether we have mesangial and subendothelial, so we have class 3 or class 4. So this is important. Again, the important point is that proliferative classes are the important ones. This is the activity. This is why you take the biopsy. You want to know whether you're going to treat the patient or not. You want to know what's happening in the kidney. So if I have, like in this last cartoon, dominant mesangial deposits, but also dominant subendothelial deposits, I'm not going to classify it as 2 to 4 or as 2 to 3, because it's not important to have mesangial. And we accept mesangial deposits within the active classes. So I hope that this is clear. I just try to stress on how we classify lupus, and when is it important to combine classes, when it is important to know whether your patient has activity or not. And then we come to activity and chronicity scores. As you have noticed, I have discussed the whole classification, all the classes of the classification, but I did not mention activity and chronicity scores or indices, because activity and chronicity scores are irrelevant to lupus classification. They are independent indices on their own. They are independent scoring systems. They are not scoring systems within the classifications of lupus. So we always had the trials and the different classifications and the modifications of the classifications. And we also always had trials at different activity and chronicity indices. As you can see, we have the SLE, we have BIRLAG, we have SLAM, we have the Pollack and Pirani, Austin, Moore, etc., etc., etc. There are so many attempts for activity and chronicity scores. However, the commonest is this one, is the Austin one, and this is almost what each of us, this is what we call the NIH scoring system, and this is basically what almost everybody uses in scoring lupus GM. And this is what we call activity and chronicity indices. Basically, what we do is that we score 6 criteria, and we consider that these 6 criteria are evidence of activity. What are these 6 criteria? What we call endocapillary hypercellularity, presence of neutrophils, presence of wire loop deposits, or what we call subendothelial deposits, presence of fibrinoid necrosis, cellular crescents, and the presence of interstitial inflammation. And we give a score from 0 to 3. How do we score? By the number of the glomeruli. So 0 if no glomeruli have neutrophils, so I'm going to score 0. If less than 25% or up to 25% of the glomeruli has neutrophilic infiltrate, score 1, and so on. Score 2 is from 25 to 50. Score 3 means that more than 50% of the glomeruli either have crescents, have subendothelial deposits, or have neutrophil, and so on. However, because the presence of fibrinoid necrosis and cellular crescents are very important, these scores are multiplied by 2. So the total sum, instead of being 18, it's out of 24. So this is the activity indices. While chronicity indices are from 0 to 12, we score 4 entities, and this is where the tubular interstitium comes in. And it's really very important because, as you all know, and as I have mentioned several times before, that it's the tubular interstitial compartment and the vascular compartments are what are responsible for the prognostic or the gives you a prognostic idea about the prognosis of the patient. So we score glomerulosclerosis, we scored the presence of fibrous crescents, interstitial fibrosis, and tubular atrophy. There is advantages in the scoring and disadvantages. There is a lot of, there is no really strong predictors of long-term prognosis. And this is basically what we are working on currently in the new classification of lupus nephritis. And because, as I mentioned, the classifications now are mainly targeted towards pathogenesis and prognostic indices. And you have, of course, the Oxford IgA classification as an example of this, rather than just classifying morphological criteria. So as I mentioned, this is the score and have. So which class is to be scored? Are we going to score all classes, or do we score only 2 classes? If you looked again at the activity and chronicity indices, are actually the activity indices are present only in class 3 and 4, while the chronicity indices are present in all classes. But what we do is that we score activity and chronicity only in class 3 and 4, and we don't score the rest of the classes. This is an example for what we call endocapillary hypercellularity with a lot of neutrophils in the glomeruli here and there. This is how endocapillary hypercellularity looks like. This is subendothelial deposits on the wire loop. This is silver stain. All of this orange deposits in silver, basement membranes are black, as you can see here, and you can see a very thin black line, but all of these orange deposits are extensive subendothelial deposits in lupus, and we have even pseudothrombi, or what we call hyaline thrombi. You have some neutrophils here, you have endocapillary hypercellularity here, and this is again how we score a lupus. Each glomerulus is scored for all the lesions in it, because you don't get a single lesion in the glomerulus. You get more than one lesion. So in a single glomerulus, you're going to give a score for the endocapillary hypercellularity. It's going to be counted. You're going to count, you're going to give it a score for the extensive subendothelial deposits. You're going to give it a score for the neutrophils which are there. So scoring lupus is really a tedious and time-consuming process. Again, subendothelial deposits are very nicely represented in trichrome stain, as you can see on the right. And what I have here on the arrow is classic, what we call wire loop lesions. And as they taught us, wire loop lesions are like a hard wire, like the electricity wire. It's a rigid basement membrane because of the deposit. So it gives you a full circle, which is not the normal character of the basement membrane. And it's also bright pink. So this also reflects subendothelial, what we call subendothelial deposits or wire loop lesions. Crescents. This is a crescent. And the definition of the crescents have been modified, as I'm going to mention in few minutes. And this is the tuft. This is what is left of the tuft. And all what's evolving here, all what's occupying the bone space here is a very cellular crescent with fibrinoid necrosis. And there is a difference between having fibrinoid necrosis in the tuft and fibrinoid necrosis in the crescent. This is when we come to score, this is only going to be scored as a crescent. I'm not going to score it as having fibrinoid necrosis because this is not in the tuft. So I'm not going to increase the scoring, the activity index of the patient because of this. Fibrinoid necrosis in a crescent is a normal part of any crescent. While this is, as you can see on the right, this is H&E. This is fibrinoid necrosis in a tuft. And you can see it in the silver here as well. and there is an early crescent. So this glomerulus is going to be scored again twice, once for the crescent and once for the fibrinoid necrosis. You see, this is what fibrinoid necrosis is usually segmental, and can you see the rest of the glomerulus is really clean with absolutely nothing else. So this is segmental fibrinoid necrosis. By immuno and in classes, you can see that you have usually extensive deposits, which can be sub-epithelial and some of them could be sub-epithelial, most of them are sub-endothelial, as you can see here for most of the antibodies, and this is the character of lupus. And again, what is expected as what happened in all the new classifications of renal disease, and that we are going to include the immuno studies within the classification. And by electron microscopy, you're going to see the same deposits again, because this is active classes. All of these big black clumps you're seeing are what we call subendothelial deposits. Now, for our junior colleagues, again, these are the porocytes here up there. These are the foot processes with slit diaphragm, as you can see here. So whatever this black what we call electron dense deposits that you see towards the porocyte surface is what we call subepithelial, while here we have the endothelium and the capillary lumen, and these are RAS bodies which we see in lupus or other autoimmune diseases, as well as patients treated with interferon. But again, all of the major deposits here, as you can see, are towards the endothelium. So this is subendothelial deposits. So in this patient, or at least in this picture, we have extensive or more dominant subendothelial deposits. So this is class 3 or class 4. So what about activity and chronicity in the same glomerulus, or the way that we used to score, we write letters A and C in for the same patient, and look at this glomerulus. This is a nice green trichrome stain, and this is a glomerulus where all of this bright pink is fibrinoid necrosis, and this green is sclerosis. So already this green was fibrinoid necrosis, and it healed by segmental sclerosis, or what we call sclerotic nodules. But because there is still an ongoing activity, so there is also adjacent fibrinoid necrosis. So this glomerulus is going to be classified as active and chronic in the same time. So this is what we mean by activity and chronicity, that you can have in the same glomerulus, which has a character of lupus or any vasculitis, actually, but more of lupus, that you can have in the same glomerulus evidence of chronicity like segmental sclerosis and evidence of activity like fibrinoid necrosis. And again, it's going to be scored twice. And you can look at the one in the right, the PS stain. Again, this is a sclerotic nodules, which represent a healed acute lesion. This is what we call endocapillary hypercellularity. There is here subendothelial deposits. There is again endocapillary hypercellularity. There is an early crescent. So this glomerulus is going to be scored 10 times for each character. There is for the subendothelial deposit, for the neutrophil, for the hypercellularity, for the sclerosis, and so on. So basically, this is what we do. This is how we score a lupus GM. And this is why, before I move to the classification, this is why it's always important to tell you that in lupus glomerulonephritis, if you want really proper classification and scoring, that a single core is not enough. A biopsy with 6 to 8 glomeruli is not enough. Because if you have a patient with clinical signs or of activity like consumed complement, like high double-stranded DNA, whatever, but she's still nephrotic and she has a lot of nephrotic proteinuria, and then you give me a biopsy of 8 or even 10 glomeruli, and the biopsy only shows class 5, and then you want to know whether this patient is active or not, I cannot tell you, because we have seen cases with biopsies more than 25 and the activity is present in a single glomerulus or in 1 or 2 glomerulus. So bear this in mind, that in lupus activity, especially if we have a combined class, that sometimes if it starts as class 3, it cannot be easily detected. It acts like FSGS, for example. So we need a lot of glomeruli, we need a good biopsy for proper classification to detect whether we have another class or not, to properly detect activity, to properly evaluate chronicity, and not to give weight for a single, for example, excess weight for crescents and fibrinoid necrosis, or maybe the rest of the glomeruli does not have that much crescent. Now, in 2018, finally, we started to have a second look at the classification of 2003 with the revision of the International Society of Nephrology, again, a revision of the ICE-N RPS classification. What they did in the first phase was clarification of definitions. So the definitions were clarified and some of them have changed. And they had modified the NIH activity and chronicity indices. So currently, the way we score lupus is different than the original scoring system, and I'm going to show you how. So again, this can reflect differences in the pathology reports, can reflect differences in the scores if you're taking a second opinion, for example. And so you need to know why the difference is. If one of the pathologists are not following the new, the modified activity and chronicity indices, and they are entitled to, then, and the other pathologists are following them, then this is going to create differences in the scoring systems. As I mentioned, and I'm stressing, we don't have a new classification yet. We are still using the 2003 classification, and that this revision is phases which are going to follow evidence-based studies. So we only have phase 1 since 2018. In phase 1, there was a proposal for scoring in all classes. So there was a proposal that we should score in all classes, whether it's class 1, 2, and class 5. We already score in class 3 and in class 4, but there was a proposal. But this is just a proposal. I, for example, still myself do not score in all classes. I still only score in class 3 or class 4. We're waiting for evidence-based to tell us the utility for scoring in all classes. As you've seen, scoring is not really fun. And then this is the proposed modified NIH lupus nephritis. This is the activity and chronicity scoring system. Without getting you into too much pathology details, one of the main things that changed is that scoring of that the chorecyst's, which was part of fibrinoid necrosis, and which had led to an estimation of the presence of fibrinoid necrosis in the biopsies, is now redefined as part only of presence of neutrophils. So neutrophils are only scored from 0 to 3, while fibrinoid necrosis is scored out of 6. As I mentioned, it's multiplied by 2. There is new definition for what we consider cellular and fibrocellular crescents, again, which had led because there was overestimation for activity of the crescents. Now we only consider crescents active, and they should be scored as active crescents within the activity indices if they have less than 25%, if they have only up to 25% fibrosis. That means that if a crescent has more than 25% of fibrosis, we do not consider it, we consider it a fibrous crescent. We don't even consider it a fibrocellular crescent. Also, the chronicity indices have changed. As I mentioned, the definition of crescents itself has changed. It does not involve 25% of the Bowman's capsule right now. The definition has been modified to only include 10%. So if I have extracapillary proliferation, which involves only 10% of the Bowman's capsule, then this could be, is a crescent. Again, in the chronicity indices, there is a total glomerulosclerosis score. The chronic score for glomeruli includes both global and segmental sclerosis, not only global sclerosis. And this is really important because it reflects the burden of the glomerulonephritis. It reflects the extent of the changes which occurs. So this is basically what have been changed. As I mentioned, there have been a clarification of all the definitions that we use to diagnose classes. So we have used the same definitions that were used in IgA nephropathy to identify mesangial proliferation, to redefine what we call chorecyst's and neutrophilic infiltration. As I said, the definitions of crescents have changed. What we consider a fibrous crescent and whether it's a synecdoche, as you can see in D, and so on. So there have been a lot of changes in the clarifications and in the definitions of what we used to diagnose with or what we classify lupus based on. whatever all of these changes have been happening, because we always have to remember, and whatever classification that we're using in lupus, what you always have to remember that these are classes and not stages of diseases. We always stress on this point, again, for our junior colleagues, because when they are first introduced to the classification, and because, of course, patients with mesangial lupus have a more calmer clinical presentation and a more quieter clinical scenario than what we see in active lupus or even in class 5. However, these are not stages of the disease. These are just classes, and patients do not have to go from class 1 to class 6. It does not go this way. And class transition can occur at any stage of lupus as well. So patients do not have to start the presentation with lupus glomerulonephritis or with lupus nephritis as class 1 or 2. No, sometimes the first presentation, as most of you know, is with class 3 or class 4 or with class 5. And there is class transition, so patients change. So this is why I always get surprised if we have a lupus patient and then they are sending a biopsy 1 year old for a second opinion, because the patient has a presentation now. The patient now has renal impairment. The patient currently has proteinuria, and the patient had a biopsy a year ago or 9 months back, and they want this biopsy to be revised. And in lupus, this biopsy is not going to tell you anything about what's happening with the patient right now, because this is a dynamic disease, because patients can develop other things, and you could have class transitions. So it could be useful in a patient with a nephrotic presentation of 3 or 4 years, or in a patient who had a biopsy 2 years back, was diagnosed as FSGS, patient not responding, and you really want a second opinion. But in lupus, it's not going to help you. If you want to know why your patient has renal impairment now, in lupus, I'm not going to help you. It's not going to help if you want to look at a biopsy which was taken even 7 months back. So cases can jump from a lower class to a higher, worse class. So the patient could be class 2, patient could be a class 5 and then jumps up and become class 3 or class 4. Patients can jump directly from class 5 to class 2 without passing through active stages. And patients can change from class 3 to class 2. Class transitions are much more common in lupus than you can imagine, as I'm going to show you now. Always remember as well that class 3 and 4 can be complicated by segmental sclerosis, like when you have healing of active lesions and persistent, and then patients will have persistent proteinuria, as I've just shown you. So any lesion of these active lesions, necrosis, crescents, endocapillary hypercellularity, is going to heal by segmental sclerosis. And these patients are going to have persistent proteinuria, and of course, you know that this is injuries to the kidney. Remember the tubulointerstitial disease, tubulointerstitial inflammation, or the tubulointerstitial status in general is very important, and the vascular changes are important. Lupus is not a glomerular disease. It's a renal disease. And what is going to judge the prognosis of your patient is the tubulointerstitial state and the vascular changes, not the glomeruli. And what we always tend to remember, and I'm going to leave this to the end of my talk when we discuss the role of biopsy in lupus, the patients undergo subclinical changes, and mainly thrombotic microangiopathy subclinically. And it's one of the main reasons why patients seems quiescent clinically, but then all of a sudden they come presenting with a serum creatinine of 6 and end-stage renal disease. As I mentioned, the severity tubulointerstitial compartment is what's directly related to the creatinine level, to the decrease of the GFR. The tubulointerstitial scarring is what is related to the prognosis of your patient and response to treatment, and it's what should make you evaluate whether, even if this is lupus and even if it's active lupus, whether this patient whether you should really administer aggressive treatment or not. However, the current classifications and the current activity and chronicity indices do not really properly address the tubulointerstitial changes, and definitely they do not address at all the vascular changes. So we don't have any scoring system for vascular changes. We don't have any class which includes vascular changes. You know that the vascular lesions in lupus are arteriosclerosis and hypertension-related changes. All of these patients are hypertensive. We can have uncomplicated vascular immune deposits. We can have lupus vasculopathy, which is non-inflammatory necrotizing vasculopathy. And more important is that we can have thrombotic microangiopathy as a manifestation of lupus itself. It doesn't have to be an association with something else. And we can have necrotizing vasculitis, which looks like polyarteritis nodosa. This is uncomplicated vascular lesions, as you can see here, and these ones are usually immunopositive, and they will stain for antibodies. They always usually stain for IgM. So this is just extensive immune complexes, which are deposits within the vascular wall. This is what we call a non-inflammatory necrotizing lupus vasculopathy, and this circle actually presents a whole wall of an artery, and there is no muscle wall anymore. It's all replaced by fibrinoid necrosis, and there is inflammation surrounding it. And this is thrombotic microangiopathy. You can see here there is a thrombus in the hilum, and again here minute thrombi within a lupus patient. Okay, I'll spare the last 10 minutes or maybe less for what is the role of renal biopsy in lupus. Now, the role of renal biopsy in lupus is not to diagnose lupus. Now, this is number one. We do not diagnose lupus from biopsies. We can suggest that this is lupus from the biopsy. We can suspect that this is lupus from the biopsy. But lupus is a clinical diagnosis. So you need to know that your patient is lupus. And if you don't know that your patient is lupus, and if the biopsy suggested for you that it's lupus, you still need to confirm serologically that this patient and clinically that this patient is lupus. So please, pathology reports are not for lupus diagnosis. And remember that although it have been included within the latest, or I don't know if there is an updated classification in rheumatology for a lupus or not, or updated criteria, but even since they included the biopsy within the criteria of a lupus diagnosis for the American Rheumatological Association, it's still included that it has to be with the biopsy and the serology, which is negative, at least ANA. So you cannot just the patient which is seronegative, and then you decide that it's lupus because the biopsy told you that it's lupus. So this is number one. Number two, we take the role. What we do with the biopsy is a lot of things. We score, we classify, we give you prognostic indices, we give you an idea about the status of the kidney. It guides treatment if the patient, because through the classification and so on. But in lupus, as you do in transplant, it is often indicated to repeat biopsies whenever something in the clinical picture does not fit. Meaning when you have dissociation between clinical and histological findings. And this exactly applies to just the example as I mentioned. You cannot have a lupus patient which is currently presenting to you today with proteinuria or with renal impairment or with both, and then this patient had a biopsy 7 months back, and then you want to revise the biopsy because you don't want to take a new biopsy. This is not going to happen, especially if her clinical presentation does not fit with what you have in the biopsy. Why is that? Because when you repeat the biopsy, there are other lesions which can be seen and which are really important, and that you do not consider. So the biopsy is not only for classification and prognosis. In repeated lupus biopsy, you can detect persistent histological inflammation, which is the main drive for end-stage renal disease, or which is evidence-based linked to the occurrence of future kidney relapses. At a relapse, if the patient is currently at a relapse and she's presenting with proteinuria, the biopsy, and even if you can see that this is clinically just a relapse from a further activity, will detect histological changes, which includes chronic scarring, which could have occurred within, yes, it could occur within the lapse of 2 or 3 months. And patients with a clinical response, and you have them on maintenance immunosuppression, then a repeated biopsy can also aid therapy, tapering and or suspension. Now, let me show you a very nice, yes, but more important is that you could be surprised that the biopsy shows something else. a completely different pathology. Because although these are lupus patients and although they have renal impairment, it's not always lupus. These patients can develop other diseases, and you know better that there are other renal manifestations in lupus than lupus nephritis, and that lupus patients can develop other diseases, like they can have ANCA, vasculitis, they can have amyloidosis, and they can have a lot of other changes. We know that patients have thrombotic microangiopathy. This is the commonest other renal manifestation that we see than GN. We have silent lupus nephritis, and we're going to talk about it. We have ANA negative lupus nephritis. Now, this entity, or what we used to call seronegative lupus, I think always that this is some form of a wastebasket, and it leads to overdiagnosis, unnecessary overdiagnosis of lupus. And this entity, I want just to remind you that it became rare. If it was common before, because we did not have new techniques and no new cell lines to detect the ANA properly, we're actually now suffering from overestimation of lupus, and that a lot of patients are ANA positive because of the new cell lines. So be very careful before you decide that you can have an ANA negative lupus nephritis. It occurs, and follow up these patients before you decide that they are lupus. Because even if they start ANA negative, they are going to turn positive, eventually seropositive within 6 months or maximum a year. And this scenario usually can occur with patients where their first presentation is class 5. So those lupus patients who have a first presentation or in their first biopsy, either it's class 5 or a membranous GN, they can originally or initially be ANA negative. But then they eventually turn positive, but they can take up to 1 year. We know that patients with lupus could have ANCA positivity, and then we have the entity of lupus porocytopathy. Now, lupus porocytopathy is again a bit of a debatable entity. Some do not believe in it at all, and others believe too much in it, so it's an overdiagnosis, and it leads to an overdiagnosis of lupus as well. So if we have a patient with minimal change disease and FSGS in biopsy and with a nephrotic syndrome, a steroid-resistant nephrotic syndrome, and just ANE positive, just don't simply call it lupus porocytopathy. Just make sure that your ANA positivity is valid, that you have other features of lupus nephritis. I mean, really properly diagnose your patient as lupus before you decide that this is a lupus porocytopathy. Okay, this is a very interesting review which have been published earlier this year. And this review article have mainly targeted the role of biopsy in lupus, and it's mainly what we are concerned about in relation to lupus nephritis currently, that the discordance between the clinical and histological remission. As you can see here, and as I'm going to show you, these are studies from patients who are represented either with complete response or with a partial response and had repeated biopsies at certain time points. So you can see in this study, they had 45 patients, 28 of them had came back for the second biopsy, and at 6 months, 18% of these patients showed activity. And these are patients who had a complete clinical response. But at 6 months, they still had histological evidence of activity. Another study had a time point at 8 months. They had 71% of their patients, and they had only 17 patients. Sorry, these ones were 28. They had only 17 patients. 71% of their patients at 8 months post complete clinical response to the activity had evidence of histological activity. And then at a time point of 12 months, that's 1 year later, now they had only 4 patients who were submitted to the second biopsy, and one of them still had histological activity. And you can see here with larger studies who had biopsies at 36 months, 56% of the patient had evidence of histological relapse with no clinical relapse. Classically, what we call silent lupus nephritis or subclinical activity. And you can see here at 42 months, 78% of the patient had histological changes which were not reflected clinically. And when we approached 48 months or more than 48 months, these studies had showed 100% of the patients. Again, when we apply the same thing for the patients with partial clinical response, and you can see again at 6 months, we had 20%. At 1 year, you had 17%. At 30 months, 55%, and so on. 48 months, we had 29%. So this data shows you how much discordance we have between the clinical response of your patient and what actually is happening in the kidney. And so these patients whom you thought that they have a complete response to their lupus GN actually have subclinical histological changes. And as I mentioned, these are the patients which go apparently clinically controlled and then come to you after 2 or 3 years with end-stage renal disease, and you don't know why. These were post-treatment kidney biopsies performed in 20 patients with lupus nephritis from a Mexican cohort due to non-response to therapy. Now, and so here they had an indication for the second biopsy because they were non-responder. And it's interesting in this study because I want to show you the change in the change in the classes. So they had, this was the ISN, RPSL, and biopsy class in the biopsy 1, and all of them they had class 5. But look here, they still had, now they were mainly here active, they became active and chronic, and this in a year, 12. So second biopsy with 8 months, 16 months. And in 6 months, in this patient who had class 4 active and chronic plus class 5 and was non-responder and had activity index of 9 and a chronicity index of 7, actually in 6 months, not only did he not respond, the new biopsy showed thrombotic microangiopathy. And you can see how the new biopsy have led to immunosuppressive therapy modification, whether intensification, whether decrease, because this patient was non-responder. And as you can see here, from class 4A, they have changed to class 6 here in this scenario, in the second scenario. So there was decrease of the immunosuppression. Again, here, these patients became very chronic with a chronicity index of 10 and 9. So there was decrease in the immunosuppression and so on. So actually, what was happening is that these we had so many changes. Based on the second biopsy, there were changes in the immunosuppressive therapy modification, as well as in the changes which were actually seen in the biopsy. Now, this is also comes from different studies, as you can see, as old as from 1993 up till the latest study is in 2022, just 2 years back. And I want you to look at all of these studies. These studies have the second biopsies or the repeated kidney biopsies in these patients were performed for diverse indications. So the indications were no response to therapy, so they were non-responders, or these patients had persistent proteinuria, or these patients had suspicion of relapse, so or deterioration of kidney function. So basically, this was the indications. And I want you to look at the last column here, that this is the total lupus nephritis class transitions, which has been detected between the different repeated biopsies. How many patients had non-proliferative and non-proliferative and proliferative, non-proliferative to proliferative, and proliferative to non-proliferative? So this is the class transitions, and you can see the number of patients, 55% of patients have class transitions, almost always around 50%. Some had 65%, and this is the latest study, at 65% of the patients had class transition. Some of them from non-proliferative to proliferative, so they were not active, and they have changed to activity, and some of them were proliferative to non-proliferative. Again, remember that they did not really show signs of activity. So to sum up, the utility of basically renal biopsy in lupus nephritis. So the first utility is initial diagnosis. So at the initial presentation of the patient, the biopsy is going to provide you with a diagnosis. It's going to tell you activity and chronicity. It's going to tell you the class, the ISN-RPS class. It's going to inform you whether you have non-classical etiologies. For example, if the patient has something else, incidental amyloid, for example, if you have a suspicion for ANCA vasculitis, a lot of Crescents, whatever. And if you have a clinical trial, then the initial presentation is going to help you to select for the clinical trial. However, the initial biopsy that you take and that you stick to, because the patient had been diagnosed as lupus class 4 2 or 3 years back, and sometimes that we see in the requests, has limited prognostic value. This initial biopsy or this first biopsy, or for most of you here or most of us, this is the single biopsy a lupus patient takes, has limited prognostic value. It's never going to tell you how this kidney is going to perform or how this patient is going to respond. Then when you have a lack of response after 3 to 6 months of initial therapy, it's really recommended to take another biopsy. Please do, because this biopsy is very important. It's going to tell you whether you have a resistant lupus nephritis and you need to start in a different line of management. Or it's going to tell you whether you have irreversible damage. Some patients, by the way, are not going to respond and are going to be end stage. And you keep them on maintenance immunosuppression and you keep trying when the kidney is lost. So it's going to tell you if you have irreversible damage. Again, if there is something non-classical or non-lupus going on, and if you need to change of therapy. And in 3 to 6 months from the first biopsy or from the initial presentation, it's going to give you good information about long-term prognosis, because then chronic changes, if they were going to have chronic changes, they would have settled in. From my opinion, what's even more important is that you need to have a post-therapy biopsy, which is after 12 to 18 months of initial therapy. If you want, and what some currently calls it protocol biopsy or lupus surveillance biopsies, and that after a year to 12 to 18 months of initial therapy of the first presentation of the patient, you really need to take a biopsy. This biopsy is going to tell you whether you have a full histological response or whether you are having a subclinical activity, whether you have proteinuria from activity or chronicity, residual, and if you need to adjust your therapy, whether to decrease it or to intensify it. It will also give you good prognostic indices. You're going to know the long-term prognosis of this kidney, because you'll have a better idea about the status of the kidney as per chronicity, and it's going to give you an idea about the risk of kidney relapse. It's going to tell you this patient is at high risk that it's going to relapse, and then you might need to intensify your immunosuppression. If the patient relapsed, and this is exactly what we were saying, if there is a new flare, you need a new biopsy. So because then the new biopsy is going to tell you which class you are in now, what are you facing, whether you have a vascular disease which is aggravating it, whether this is mainly chronic with a minimal activity, and so on. So at a new flare, before you start treating the patient, you need to know, even if the patient had a history of activity, you need to know what are you dealing with currently. And of course, if you want to have drug withdrawal after 36 months of remission, again, do not withdraw the immunosuppression without a biopsy, because you need to have a complete histological remission and decision-making, and this is going to support your decision for therapy tapering and or suspension, and if the patient have a risk of kidney flare during tapering or suspension. So take-home messages is that we still have problems in the clear classification or the categorization. We still don't score all the important entities. We still need to change the way we look at the role of the biopsy. In lupus nephritis, this is very important. We still don't have enough validation studies in relation, because at the end of the day, our target is that we who work with renal patients, the target is that these patients do not get to end-stage renal disease. The target is not that when they get to end-stage renal disease that we treat them, or that when they have. So the target is that we prevent them from developing end-stage renal disease. And in order to do this, we need to think differently. We need always to know what is happening with this kidney. We need to know that our patients who has a flares autoimmune diseases could have subclinical activities. We still lack of precise definitions, and we're hoping that the revision of the classification is going to solve this problem, and that it's going to make it easier for all of us, more reproducible for all of us to use, and that everything is going to be more clear. And remember, and as I always say, whenever we discuss any classification in relation to any disease, it's not important to place the patient in a class. There are some patients where you cannot classify. You cannot put them in a class. So remember that patients do not have to fit into a class. Sometimes there is no class to describe this patient. So then you need to read the pathological details carefully. You need to look at the morphological details carefully. The pathologists need to rephrase their diagnosis in order to really reflect what they see or the status of this patient, because again, this is what's going to guide treatment and management. Thank you very much.
Thank you Wesam very much. يعني محاضرة رائعة comprehensive، استعرضت كل يعني الباثولوجيكال كلاسيفيكيشن على through the years والchanges of the concept بتاع الكلاسيفيكيشن، وازاي ان عايزين ندخل فيه البروجنوستيك فاكتور والتشينجز والدايناميك بروسيس. ويمكن واحده من النقط الاخيره اللي ان شاء الله غالبا هتفتح مجال كبير جدا للدسكشن، وهي الديسكوردنس بين الكلينيكال والهيستولوجيكال ريسبونس والسجستد 5 بوينتس رينال بايوبسي انيشال وريزيستنس وفلير والويزدرول ومع الاند اوف تريتمنت. دي 5 بوينتس. هنوافق على 3 منهم، 2 ممكن مش هيبقى كلينيكالي انديكيتد قوي. اعتقد ناس كتير قوي هتعلق على الموضوع ده، يعني هتبقى صعبه.
انا عارفه
هي
انها
برضه
هتبقى خناقه، بس انا قلت يعني نبتدي
5
خناقه
بوينتس 3
كده
ماشي،
بنبتديها
3
بدري وممكن ده بعدها تكمل يعني.
لكن طبعا
معلش لو
مسألة
وصلنا
رائعة
ل2
رائعة
3 من
وفولفيل بكل
ال5
حاجة.
يبقى كويس. نعم. ميرسي يا حاتم.
3 كلينيكال جاستيفايد انيشالي، والريزيستنس يعني يا ريت في الريزيستنس فعلا، بس الريزيستنس حتى على الهيستولوجي يعني هيبقى برضك مش هيديني كل الريكوايرمنتس اللي انا عايزها ككلينيشن. يعني العيان ده في الاخر خالص هتقول لي الهيستولوجي بتاعه كذا، مش ريسبوندد او حصل فيه كذا او بقى فيت تشينجز
هو
الستيج
المهم
بتاعته.
انك تعرف ان هي
لكن
ممكن العيان يبقى مش ريسبوندنج عشان بقى اند ستيج، ممكن يبقى مش ريسبوندنج عشان يديفلوب ذا فاسكولار ليجن ما كانش موجود في الفيرست بايوبسي.
ايوه
هي دي الامبورتنس. احنا بنشوف
انا
عيانين
اعتقد
كتير قوي يا حاتم، بيجي بايوبسيز فيهم، بيجي بايوبسي وبعدين اقول له ان ستيج، يقول لي ان ستيج ازاي؟ العيانه was very well controlled، بقى لها 3-4 سنين ماشيه على المينتنس ثيرابي، she's very well compliant، ودي جات لي فجاه بكرياتينين 6. هو ده اللي احنا بنتكلم عليه، البوست ثيرابي بايوبسي. هم دول العيانين دول we see them frequently in clinical practice. وانا متاكده ان كل زمايلنا اللي بيسمعونا كان relate to this scenario. عيانه اللوبس اللي انت ماشيها كويس وشايفها well controlled، وفجاه جات لك بان ستيج مش عارف ليه. هم دول العيانين
هو ده اللي
select
نرجع تاني
الديسكورد.
نقول يحدد definition of response. definition of response what does
طبعا.
it mean؟ هل هو بروتينوريا وكرياتينين بس، ولا
بس انت
في
شفت ان
another marker biological markers؟
حتى اللي بكمبليت ريسبونس as per definitions، ما هو البروتونوريا، ما هو ممكن يكون عندك complete response وعندك residual proteinuria from a chronic lesion، مش هتقدر تعتبر ان ده is evidence of histological activity برضو. عموما انا شايفه ان في حاجه، في مسجز كتير قوي على الشات.
كتير. بس دكتور ايمن رفاعي كومنت الاول، اتفضل.
اتفضل دكتور ايمن.
Thank you very much, Dr. Wesam. يعني brilliant as always. يعني I really enjoyed the very smart, rich, comprehensive presentation about the utility of renal biopsy in lupus patients. I would just like to highlight our clinical practice that we suffer from the lack of early referral to nephrologists from the two
ده حقيقي.
other specialties concerned with lupus from rheumatology and dermatology. And we should encourage the early referral for the early biopsy and early diagnosis. Also, as Dr. Hatem mentioned, that very important, the slide of the discordance between the clinical and remission. And I think this raised the importance of the follow-up biopsy in cases with remission. I'm one of the fans of the surveillance biopsy and protocol biopsy in the field of transplantation. And I think this should also be implemented in cases with complete remission. Of course, in our clinical practice, we go for rebiopsy in resistant cases, but we don't perform biopsy in the cases with remission. But this is very important, as you mentioned, to take the decision either to continue, withdraw the immunosuppression. And as you mentioned that when you describe the different classes of lupus, of course, sometimes it's very hard, it's frequent to find the sharp demarcation between different classes. It's not always black and white. So what nephrologists need to know always what's about the activity and chronicity indices, because this one of the therapy will be how aggressive are we going to be in the immunosuppression depending on the activity and chronicity. But I think we should not forget in the same time that lupus is a systemic disease, and the chronicity of lupus nephritis in the biopsy does not mean that we do not need to be aggressive in treatment. If there are systemic manifestations or activity or high titer or positive of the lupus serology, and we all see that many of our lupus patients on hemodialysis still need to be on immunosuppression in the form of steroid or even on MMF. I do thank you for this very elegant presentation and raise the new concept of follow-up renal biopsy in the cases with remission. This is very important. Thank you very much.
Thank you, Dr. Ayman.
Thank you, Professor Ayman. Thank you, Dr. Ayman. نبدأ الخناقة. Question from Dr. عبد الحميد أمين. If there is dissociation between clinical and doctors, did you treat clinically or pathologically? إيه رأيكم؟
Both.
Both. هو
إزاي؟
clinically هو لا يعني you need هي نفس الفكرة على فكرة، نفس الخناقة بتاعت subclinical rejection في transplant.
Yes.
Yes.
It depends على السبكلينيكال اللي موجود ده subclinical activity قد ايه. You need to intensify your maintenance immunosuppression. You don't have to give a management, but it gives you an idea that this patient is not properly controlled. هي دي كل
هي
الفكرة.
كل الجايد لاينز في
هو احنا بنقول ان في
treatment
clinical
based على
pathological
approach.
discordance. نعم يا حاتم؟
هي كل الجايد لاينز في التريتمنت بروتوكولز قائمه على الباثولوجي.
طب خلينا
بالظبط.
do you expect ان هو لو
لو
patient
مشينا
مثلا
على الكلينيكال سنس ما هو ده اللي احنا بنقوله exactly ان العيانين دول مش presenting clinically.
طب خلينا اسال سؤال، ان هو لو لقينا، هل نتوقع ان نلاقي عيان rapidly rising creatinine او rising creatinine يعني مش stable، proteinuria is increasing، ونلاقيه كلاس 2 مثلا في الباثولوجي مفيش اي proliferation؟
هو ده usually بيبقى ان either البيوبسي مش sufficient ما did not. وانا دايما بكتب في كومنت في البيوبسي، لو انت شايف ان العيانه اكتف treat. لو البيوبسي is insufficient، لو البيوبسي فيها 10 جلوميرولاي ولا 12 جلوميريلاس زي ما انا قلت، although ان دول are by definition adequate, they are not adequate to 100% exclude ان انا ما عنديش active lesion. ودي بتحصل كتير في الدي تو داي براكتس، ان باعت لي عينه دبل ستراند دي ان ايه عالي consumed complement وكلاس 2 وانا عندي 10 ولا 12 بيوبسي 12 جلوميريلاس.
طب لو
خلاص
الجلوكوز
اكتب ان I cannot exclude activity and then you can go on your clinical sense. لو العيانه انت شايف ان العيانه has a flare lupus treat.
طب لو البيوبسي كان اوكير بسفشن بيوبسي
لو sufficient biopsy proteinuria increase أنا ساعتها I would recommend EM. Definitely there is something else which is happening. في الآخر بالضبط في الآخر الكلينيكال يعني الكلاسز more or less بالكلينيكال كلاسيفيكيشن بتاعهم اللي احنا عارفينهم، الا لو لقينا مثلا a new study which follows up patient وبتقول لنا ان كلاس 2 ممكن البروتونوريا تزيد، مش expected، ده مزنجل. بروتونوريا زادت يعني we invert the basement membrane or we go again to the pathogenesis. برضو يعني I want to remind you وترجعوا with your own experience which is extensive طبعا and much more than mine، بس how many lupus patients with a pure lupus activity وما عندهمش chronic scarring وما عندهمش associated vascular lesions وما عندهمش حاجة تانية بتحصل. Do you really see with severe renal impairment lupus activity is mainly proteinuria. If I have a patient with lupus activity and high creatinine احنا بندوخ عشان نعرف الكرياتين عالي ليه. There has to be a reason why there is high serum creatinine. Lupus activity alone by default ما بتعملش severe renal impairment. مش هتجيب عيان لا renal failure ولا with high creatinine. بيبقى في حاجة تانية بتحصل. You have a vascular lesion, you have an extensive tubulointerstitial disease, there is something else going on.
something pathology also
Yes.
مش
there is I mean
لا
هو ده exactly what we mean by non-classical etiologies.
extraglomeralia
So yes ما هياش بس الactivity او اللوبس.
مش
مش منطقي. لا
بالظبط.
اللوبس activity مش بتعلي كرياتين قوي كده.
م.
So if there is some ما هو this is exactly what we're saying. If clinically patient does not fit within what you think the pathology will be, then you need to repeat the biopsy because there is something else going on.
Okay. Question I
هو
think
الثيرابي يعني initiation of therapy depends only on
الصوت مش واضح يا دكتور.
on the clinic. The initiation of therapy depends mainly on the clinical presentation. يعني I should not wait for the pathology except in يعني quiescent cases, case with the normal kidney function, just proteinuria, nephrotic presentation. I can wait for the biopsy findings. But in many cases, we are confronted with something like rapidly progressive renal failure with lupus. I should start aggressive treatment early without waiting the result for biopsy. And the biopsy later on will help me to, do we need to add on or adjuvant therapy after the initial steroid pulses and so on. So I think presentation is very important in the initiation of therapy. Should I wait for the pathology or should I go aggressively without waiting the pathology report?
هو حضرتك
الرابيدلي بروجريسيف زي ما قلت هنتريت ازيف ان هي فعلا سيفير بروليفراتيف لوبس وكريسنتيك وهنعمل كده لغايه ما الباثولوجي يطلع. بس برضو الدكتوره وسام قالت في بوست محاضرتها ممكن يطلع اي تي ان، ممكن يطلع تي ام اي، ممكن يطلع حاجه ثانيه في الباثولوجي اكسبلين الرابيد ديتوريشن في الكدني فانكشن، ففي اذر اسوشيشن. بس طبعا ككلينيكالي بيزد لا كلنا هنعالج ان هو لا رابيد بروجريسيف واكيوت بروليفراتيف وسيفير بروليفراتيف وكريسنتيك، وهنعالج اميونولوجيكالي لغايه ما تطلع البيوبسي.
هو سؤال حضرتك دكتور
انا
ايمن
اتفق مع حضرتك
اتفق مع حضرتك تماما. هو سؤال حضرتك دكتور ايمن بيفكرني ب مره في احد مؤتمرات القصر العيني عندنا كان عارف خواجه من شيفيلد موجود بيقدم كيسز عن اللوبس، وكان كل المحور تقديم الحالات ان احنا تريت لوبس without a biopsy، يعني we don't need biopsy for treatment of lupus we should start treatment. فسألته سؤال في الآخر all of these cases needed biopsy at some point of the stages. قال لي yes كلهم خدوا في الآخر biopsy. ففي النهاية وصلنا للبيوبسي. قلت له طب انت يعني في حالات لوبس هتقدر تمشي بكل رحلة التريتمنت من غير ما تاخد biopsy at any time؟ قال finally no I will take a biopsy at any point of the patient course. ففي النهاية حتى لو ما بدأش ببيوبسي أو حتى لو في الآخر بدأ الإميونوسبريسيف تريتمنت I think إن البيوبسي هتتعمل في وقت من الأوقات. فالأحسن طبعا إنها تتعمل في الأول عشان تبقى الأمور واضحة بدل ما تكون effect of immunosuppression and etc والكرونيسيتي الأكتيفيتي وكل الفاكتورز affecting البيوبسي.
هو ما فيش غنى عن البيوبسي. هي الفكرة كلها يعني أنا بعمل البلس وبعمل البيوبسي تاني يوم أو in the same time. يعني أنا ما فيش غنى. أنا مجرد أنا مش عايز أبقى ليت، بس لو هي كريسنتك مش عايز استنى تبقى فايبرس كريسنتس، مش عايز يعني عايز أبدأ بدري. لكن لا غنى عن البيوبسي وإميديت. فالاتنين بيتموا في وقت واحد. زي ما بيجي لي واحد بالظبط سسبكتد ريجكشن ببدأ بلس سترويد وبعمل جرافت بيوبسي in the same time.
هو القرار هيبقى للإميونوسبريسيفز يعني other immunosuppressives
طبعا
لكن اعتقد قرار
البيوبسي هتقول لي الريجيمين هيبقى ايه ليتر اون. يعني انا هضيف ايه وهمشي على مينتنانس ايه. ده مهم جدا.
ده متفقين عليه. سؤال دكتورة وسام did you see zebra bodies in lupus patients secondary to placonil from دكتور عبد الحميد أمين؟ مش عارف
الحقيقة ما شفتوش in association with lupus، شفته لوحده يعني as a febris mimic. yes we've seen طبعا. ما هواش common very يعني very rare، بس ما شفناهاش عمرنا frankly في patients في lupus في lupus patients. في rare patients كده كان عندهم يعني light microscopy changes suggestive of this، اللي هو ان هم عندهم febris mimic or phospholipidosis iatrogenic phospholipidosis. هي دي معنى ان هو يشوف زبرة باريز. بس ما كان العيانين دول ما عملنا لهمش اي ام، بس based on the suspicion الكلينيشن يعني have withdrawn البلاكينيل. فالحقيقة لا ما شفناهمش they are not frequent. It's not a common complication.
اوكي. اعتقد باقي الاسئله questions answered. question اعتقد please حاتم TMA in biopsy means activity or associated antiphospholipid syndrome and if treatment changes based on TMA associated with lupus activity.
هو ال TMA in the context of lupus بتمثل special entity. هي ال TMA secondary يعني secondary لكتير من البروسيسز. يعني في برايمري TMA والسكندري ده احد الاسباب بتاعت السكندري لللوبس والاذر الكونكتيف تيشو ديسيزز. وطبعا ليها رول مختلف حتى في الجايد لاينز، وبتمثل اندوثيليال انجري وكومبلمنت ديسريجوليشن. هتحتاج تتارجت الباثوجينيسيس دوت ديفرنتلي عن اللوبس، لان ده ديفرنت باثولوجيكال وكلينيكال ديسيجنز مختلف وتريتمنت مختلف. بس ما هواش اكتيفيتي لللوبس بير سي، ولا هو بس سي عشان هو بيسال كمان اسوشيتد مع الفوسفوليبيد ولا لا. هو بيبقى اسوشيتد، هو سكندري فورم اللي كتير من الميكسد كونكتيف وكونكتيف تيشوسيز، واحده منهم اللوبس والانتي فوسفوليبيد. لكن ما هواش احد الانديكيتور او احد الباثولوجيكال اكتيفيتيز لللوبس بير سي، وليه بروتوكول فور تريتمنت لوحده اندوثيليال ديسفانكشن والكومبلمنت ديسريجوليشن.
اوكي. هو كده كل الاسئله.
معلش سنجل كومنت بس على الموضوع ال TMA. I totally agree طبعا مع اللي حاتم قاله، بس أنا بس I want to remind إن ساعات الترومبوتيك مايكروانجيوباثي دي بتبقى موجودة فاسكولار بس، وإن ساعات عيانين كتير من عيانين اللوبس دول بيبقى عندهم uncontrolled hypertension وبيجي لهم accelerated phase، وإن ساعات the TMA that you see in the biopsy بتبقى related إن العيانين دول خلاص قربوا يبقوا chronic kidney disease وإن هم عندهم uncontrolled hypertension. فبرضو التايمينج بتاع TMA يفرق، الاسوشيشن اذا كانت موجوده with chronic changes يفرق، السايت اوف TMA يفرق.
اوكي.
دكتورة وسام how frequent يعني أنا عارف إنه ممكن تكوني بتعاني من ال deficient كلينيكال داتا او سيرولوجي في ما بيجي لك في ريكوست باثولوجي. فهاو فريكوينت، وانت قلت ان ممكن في الكلاسز يعني من كلاس 4 ممكن يبقى ممبرنس زيه زي الريجولار ممبرنس. هاو فريكوينت ان انت بتلاقي ان لا ده بتشك في لوبس وتسالي النفرولوجيست او الكلينيشن تو ريفايز هيم سيلف ويتشيك العيان فور لوبس مانيفستيشنز او سيرولوجي اند سو اون. كتير بتلاقي كده
لا
حاجات تشككك ولا
لا
ما؟
مش كتير.
اوكي. وايه
بس
اللي
صب
ممكن يشككك لما بتلاقي مثلا حالة كده؟
لما بتبقى يعني اللي بيشككني لما تبقى كلاس 4
مم.
السب اندوثيليال ديبوزيتس، الهيتروجينيتي بتاعت الليجنز. الحقيقه مفيش ديزيز تاني بيعمل كده. يعني لما الاقي زي ما انا بقول لهم ان من كل جلوميريولس، كل كل سطر كده، كل اغنيه مختلفه تماما، كل واحده ليها شكل، كل واحده فيها different lesions. الديزيز مش يونيفورم. الليجنز اللي انا شايفاها مش يونيفورم، دي طبعا اول حاجه بتخليني اشك في لوبس. دي the first thing. الحاجة التانية إن في الممبرنس بالذات بيبقى within the clinical context. يعني لما يبقى عيان الإيدج مش ماتشنج قوي إنه يبقى معاه لوبس ويبقى فوسفولايبيز نيجاتيف، لو شكيت إن الممبرنس اللي موجود ده معاه سب اندوثيليال ديبوزيتس، ده طبعا بيبقى 90% هيبقى لوبس. لو لقيت other finding كمان مع الممبرنس جي ام، بس it's not a frequent association no. الحقيقة إن
ولو
الفوسفور
قلنا بعد
بيعمل لنا
كده،
مشاكل كتير.
لو
اتفضل.
لو قلنا بعد ما طلعتي ريبورت مثلا ان هو ده ممبرنس، وبعدين لقينا السيرولوجي طلع بوزيتيف لللوبس وشكينا في لوبس، وبيقول لك تاني بتقريها بعين تانية
اه طبعا.
وبتبداي تكلاسيفاي انها
اه
لوبس.
طبعا، لان ساعتها
اوكي.
لو انا يعني it's okay ان انا الاقي within a membranous patient شويه intracapillary leukocytes، حبه neutrophils، بالذات لو بيخلينا نشك في حاجات تانية in relation to the membranous. ممكن الاقي crescent within the context of membranous glomerulonephritis عادي and we accept it. بس if I know that the patient is lupus, then these findings are going to be interpreted as an activity. ففرق كبير جدا بين الاثنين.
وبتغيري الريبورت على
اه
انها
طبعا
لوبس
هغير
وبتعمل
الريبورت
كلاسيفيكيشن.
في الحالة دي، بدل ما هنطلعه ان ده ممبرنس وعنده 10% كريسنس، او نشك ان هو مالجننت ويا جماعة دوروا على حاجة، او حتى لو ان this is just part of an aggressive membranous. في الحالة دي العيان is going to be an active lupus patient. ف it makes a lot of difference.
شفتي في الكلينيكال براكتس عندك حالات ريبيت بايوبسي، الحالات ريميشن، ولقيتي في ريجريشن بعد التريتمنت لللوبس فايندينجز ولا
الحقيقة
ما؟
ان ما بتحصلش خالص.
اوكي، محدش بعت حاجة
لا، محدش
لحد في
بيبعت
ريميشن؟
ريبيت، محدش بيبعت بوست ثيرابي
ما
خالص.
شفتيش ريجريشن يعني اللوبس ليجن بعد
لا، بنشوف
التريتمنت؟
بس عيانين with repeated biopsies سنة، سنة ونص، سنتين، لو العيانة جت بهاي سيرم كرياتينين، ويوجولي بيبقوا خلاص
داخلين على اند ستيج.
بالظبط كده.
اوكي.
للأسف unfortunately. فهو ده اللي احنا بنقوله، إن المرحلة اللي في النص دي لا احنا ولا
مهمة
انتم
جدا.
عارفين ايه اللي بيحصل. يعني احنا مش عارفين ليه العيانة اللي كانت presenting بأكيوت أو كانت بكلاس 5 وكانت very acute kidney and should have responded ويبقى معاها only residual chronicity، جات لنا بعد 3 سنين بإند ستيج كدني. ليه؟ What happened in these 2 or 3 years؟
اوكي،
اوكي.
شكرا جزيلا. اخر سؤال انا هساله انا بقى بعد اذنكم. هل في ديسكريبنسي واضح، او يعني في ديسكريبنسي ما بين الاميونوفلوريسنس واللايت مايكروسكوبي في كلاسيفيكيشن اوف لوبس؟ بمعنى هل فعلا اللايت مايكروسكوبي از انف فور كلاسيفيكيشن اوف لوبس وسام؟
It's enough for classification of lupus if it's an active lesion.
اه
يعني أو بنفس سؤال دكتور أيمن، لو أنا مش في دماغي لوبس، يعني for example لو البيوبسي ما فيهاش غير proliferation بس، وأنا my first impression was that أنا دي غالبا post infectious GN، بس لو الاميونو اداني extensive اميونو وسب اندوثيليال وشكله سب اندوثيليال then I'm going to consider lupus. فدي نمبر 1. او لكن لو هو كلاس 4 بسب اندوثيليال بواير لوبس ببروليفريشن بي وي 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 لا I'm going to classify it. لو انا عارفه العيان lupus then I'm going to classify it 3 or 4. مش هقدر to classify 1 and 2 من غير اميونو. no way. فالعيانين اللي بيجوا بنون نفروتيك بروتونوريا والعيانين اللي جايين بنون نفروتيك بروتونوريا وهيماتوريا ونورمال كرياتينين ومش بقى لهمش كتير diagnosed as lupus، وانت عايز تعرف دي كلاس 1 ولا كلاس 2 ولا عندها early activity. ساعات العيانين دول بيطلعوا كلاس 3 باي ذا واي، برضه دي حاجه تانيه واحنا
قابلناه.
شفناها كذا مره. يعني عيان جاي بنون نفروتيك بروتونوريا ولسه ما بقالهاش كتير يعني لوبس، ولسه فيرست برزنتيشن لوبس نفرايتس، والمتوقع انها تطلع كلاس 1 وكلاس 2 according to the clinical presentation تطلع كلاس 3، تطلع early activity.
كتير قابلناها كتير
بالظبط. فاللي بيحصل لا، فانا ما اقدرش اقول كلاس 1 وكلاس 2 ولا early كلاس 5، لان مش كل كلاس 5 بيبقى واضح membranous under light microscopy، ساعات بيبقى early. ودول برضو اللي بس باللايت مايكروسكوبي من غير اميونو ممكن يتشخصوا ونسميهم كلاس 1 او كلاس 2 بيست كده بس على اللايت مايكروسكوبي، والعيان عندها نفروتيك بروتونوريا. ده سبب تاني من الديسكوردنس بين الكلينيكال اند باثولوجي، ان ما بتعملهاش اميونو وهي اصلا كلاس 5. فلا it's I can only based on light microscopy اقول دي 3 او 4. اي كلاس تاني actually محتاج اميونو الحقيقة.
question from دكتور محمد باسم. Did you find full house a non-lupus lesion?
I know ان دي entity موجودة. احنا شفنا full house non lupus post covid، يعني هم دول الحالات اللي انا شفتها وشخصتها، اللي هم كانوا full house non lupus. بنشوف full house كتير في الانفكشنز. الانفكشنز بتدي full house، هتدي عادي على فكرة. بتدي full house if it's an infection. فعشان كده بقول ان يعني كلمة full house دي مطاطة برضو، يعني full house does not equal lupus. باي ذا واي الانفكشن بوست انفكشن جي ان بتدي فول هاوس، يعني عادي تدي فول هاوس عادي، وعادي ما تديش حاجه خالص تبقى نيجاتيف اميونو برضه. ففي variabilities في الموضوع، لكن هو انا عارفه ان في recent literature بالانتيتي بتاعت الفول هاوس immune complex mediated non lupus جي ان، بس to be very honest I don't يعني I haven't reported. ممكن نكون شخصناها لان ما عنديش فيدباك يقول لي يعني if I suggested that this is lupus والنفرولوجيست ما رجعش قال لي ان دي مش lupus، بس يعني it's just a full house immune complex mediated. بس اللي شخصناهم فعلا كده كانوا البوست كوفيد.
اوكي، شكرا وسام. حاتم، no more questions, no more comments. Can we close please?
شكرا جزيلا وسام، فعلا محاضرة يعني enriched us وراجعت كل التفاصيل و provoked a lot of discussion very fruitful. Thank you very much. Thank you Dr. Yasser. Thank you Dr. Ayman. Thank you for all participants and waiting inshallah for the next coming lectures بإذن الله. Thank you very
You're
much.
welcome. Thank you very much. Thank you
Thank you
all.
very much. Thank you Professor Hatem for being with us, and
شكرا
thank you
جزيلا
for
دكتور وسام، شكرا دكتور
very
ياسر.
interesting lecture. Thank you Professor Ayman for joining us and for this very heavy and scientific interesting discussion. شكرا لحضراتكم جميعا، شكرا لكل الحضور وعلى الأسئلة الجميلة اللي أثارت المحاضرة في الآخر. شكرا جزيلا دكتور إسلام أبو نعمة our coordinator. تصبحوا على خير و excuse me to close، وإن شاء الله نقابل حضراتكم next Wednesday 9:30 مساء. دكتور معتز فتحي هنتكلم على البيدي كاثيتر انسيرشن نون سيرجيكال تكنيك. شكرا، تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.